Why are there persistent and progressive consequences to TBI? It's the secondary damage that's non-mechanical. There's also the phrase secondary impact, which means, like what happened to Dylan Stigers, you go back in after a concussion and you get hit again. That's much worse. Secondary damage is the non-mechanical damage that may ensue. So, best evidence so far, there are a number of changes in cerebral blood flow that are temporary, but a basic loss of autoregulation of both intracerebral temperature, pressure, perfusion pressure. Basically, you have a hypoxic situation induced by the chemical response, impaired autoregulation, whether there's clinically apparent cerebral edema or not. What happens subsequently is partly inflammation, partly excitotoxicity from receptor dysregulation and transmitter access, leading to cell death, theoretically, and in some cases, actually. What's the tissue damage? You have an impact, closed head injury, normal structural imaging, no evidence of intracranial bleeding, no visible contusion. It's kind of uncertain. In a specific case, you can't really tell. One theory is there's frequently axonal shearing or microvascular shearing. Sometimes an MRI will reveal shearing, but that's pretty gross. It's microscopic in most cases and not picked up. There's what some researchers call the acute fluid wave with a shock effect, not demonstrated that I know of. There are changes in cerebral blood flow and perfusion pressure. There is likely to be transient edema with relative ischemia. And of course, cerebral contusion can be microscopic also. So the response to direct tissue damage, I'm citing the same review now. Impaired regulation of both cerebral blood flow and metabolism. They're basically uncoupled. Cerebral blood flow and cerebral metabolism are supposed to be coordinated and interregulated. The regulation gets uncoupled. So you have a functionally hypoxic state relied on anaerobic metabolism for a certain period of time, which is inadequate, and an energy deficit in neuron functions. So energy is what runs the ion pump at the cell membrane, keeps the positive ions out until a receptor response triggers the change in permeability in a sequential pattern on the membrane, and you have ignition. When the pump goes, the permeability increases and the regulation gets disordered. Terminal membrane depolarization, that's what that is. So then you have a failure of the regulation of neurotransmitter availability and concentration in the intracellular space, and consecutive positive ion influx, catabolic intracellular processes, cell damage. This is just sort of a continuation of this. The cerebral metabolic demand may decrease, subsequently increase, and you have still a progressive energy depleted state that can then go into a vicious cycle because of the uncoupling of cerebral blood flow and metabolism regulation. Picture of an astrocyte. This here. Astrocytes generate and regulate the energy to run the ion pump at the neuron cell membrane. This is the Krebs cycle. I remember it, I assume everybody else does. But I won't tell you. ATP is the energy producer. Production of ATP is what the Krebs cycle does. What the astrocyte does is, to some degree, store and generate the energy for neuron function. It also recycles neurotransmitters. So it's responsible for an appropriate concentration of neurotransmitter between the presynaptic and postsynaptic neuron. So this is where we talk about glutamate toxicity in these conditions a good deal. Glutamate is among the potentially toxic neurotransmitters. The others are monoamines such as dopamine, norepinephrine, serotonin, and so forth. But an excess availability dysregulates the postsynaptic receptors, etc. If the astrocyte's metabolism fails or gets challenged, you lose that regulation, you lose the ion pump. I got this slide from John Schaefer. Illustrates kind of the same thing, but with, you get calcium influx into mitochondria, which is never a good thing. It disrupts the cellular metabolism considerably. You have then an energy deficient state leading to swelling and secondary axotomy in the axons. So that's the axon dysfunction, even though the cell hasn't been killed. The axon swells up and busts. So impaired conduction then. Mind you, this can occur in either inhibitory or excitatory circuits, or a combination thereof. So clinical outcomes are unpredictable. The other thing is inflammation. Assuming tissue damage, then you have an inflammatory response that's probably both peripheral and in the nervous system itself, generating things like cytokines and chemokines and inflammatory mediators of all kinds. But that's another form of neurotoxicity, is the inflammatory, besides the neurotransmitter excitotoxicity. So microglia are fascinating little critters. I remember being taught that glia just didn't do anything except hold things together and keep neurons from rattling. Sort of. They're actually very active. Astrocytes are the energy glia. Microglia are the inflammatory immune cells, basically modified macrophages. So if you ever wanted to see a picture of microglia, they're green. I didn't know that. Brain injury, aging, degenerative diseases will prime the microglia, which can then be activated by neurohumoral inflammatory effects, particularly chemical mediators. And they become active and themselves generate mediators like tumor necrosis factor, interleukins, reactive oxygen species. Causing cell damage. Just another blue. These are blue and red, but we know they're actually green. But But the illustration is of the neurotoxic agents and the sort of consequences, interference with the blood-brain barrier, reactive oxygen species, for which fish oil is supposed to be good. Blast injury is probably a different thing, but it's of interest now because of so many veterans coming back with head injuries, including blast. Distinguished from impact, it probably is different in certain respects from impact injury. And of course, there are many cases of blast plus impact. Generally, blast injuries seem to be associated with more neuroendocrine disruption and more chronic mood disorder and PTSD. Probably those things are connected, that neuroendocrine influences are greater with blast. But you can see that the occurrence of PTSD and depression, but not of cognitive impairment, is higher in concussion plus blast. So just a list of things you might expect to see clinically related to traumatic brain injury in patients. Cognitive impairment, certainly, but not necessarily. And, you know, if we have time, I got stories I can tell you that are interesting about this. Executive function impairment, that's a tough one. The bedside assessment of executive functions is a whole topic that I'd be glad to talk about sometime. It's not easy, but you can't get it accurately with a mini mental state or a remember three objects test. But it's significant functional impairment if the dysfunction is significant. PTSD is a fairly frequent complication of TBI. Hypothalamic dysregulation, of course, related to depression and other affective dysfunctions, which may be depressed, cycling. Post-traumatic mood disorders can appear clinically almost identical to bipolar disorder, hypomania, major depression. You have to have the history. Sleep dysregulation is pretty common and also a little hard to pick up, including sleep apnea syndromes, but also sort of generic sleep fragmentation, circadian rhythm disruptions, culminating in cumulative sleep deprivation and the consequences of that. Frontal syndromes, you'll see, you know, we've all sort of seen described the frontal syndrome of behavior. But you see that in people who don't have structural frontal cortex lesions. What they have is white matter lesions subcortically. Substance abuse is a common, probably secondary outcome. Chronic pain syndromes, pain mechanics and physiology changes in some cases after TBI. Fatigue is a big one. Generalized fatigue, neural fatigue, because of course you're running on a previously oxygen deprived brain and the reserve isn't there anymore. Autonomic dysfunctions, of course. Imbalance and fall risk is pretty frequent. So people with head injuries fall down and hit their head. And I have a patient like that 4 or 5 times. Dementia as a late outcome. Chronic headaches. That's not certainly an exhaustive list because everything kind of depends on what else has happened. Worst outcomes, these are not predicted, but they're risk factors. Prior TBIs, obviously. Any other previous brain damage, including stroke, history of meningoencephalitis, for instance, autoimmune diseases, pre-existing psychiatric conditions, which are, as we now know, really neurological conditions. Substance abuse is a risk factor. Risk behaviors, of course, high exposure to the chance of head injuries, falls, infection, inflammatory diseases, anything that the challenge the brain before sensitizes it to the consequences of whatever happens next. Cognitive functions, just for clarity, cognitive functions would be considered attention, concentration, and memory. Each of those has a number of components that have to work for their cumulative function to work. And for instance, with memory, you can have intact immediate recall and fairly good short-term retention, but impaired retrieval. So you have stored memory, but you can't call on it in a contextual way to help you with the problem you're dealing with now. And these assorted variations in cognitive impairments are pretty common with head injuries. Executive functions, briefly, to perform a problem-solving task from beginning to end. So, I need to get out of the hospital because I'm going to California to live with my cousin. Does your cousin know? Yeah, I think so. How are you going to get there? I think I can get a ride. When are you leaving? Well, I got to get my clothes. Where's my clothes? Goals and planning are impaired. That's an executive function, initiating and sequencing goal-directed behavior. That's people who don't follow up with PT, who don't cook, don't take the medicines half right, inhibiting competing actions and stimuli, going to California, conceptual reasoning, necessary for making choices, compare the consequences and risks of two things. Can you do that? Decision making, of course, is a factor. Self-monitoring and self-regulation. Think road rage. Dysfunctions in any of those, of course, do affect cognitive functioning and comprehension. So the network has something to do with these frontal syndromes in particular. This is, again, not exhaustive, but there are, for example, 3 closed circuits that have been identified in connected frontal areas to subcortical limbic areas. So interruption of white matter circuits can have effects that lead to a clinically frontal syndrome. You don't analyze the anatomy at the bedside, if at all. But for information, a lot of this stuff has its functional impact because of the interruption of circuits in the white matter. So the significance of that may be that they look like emotional problems, personality disorders, being upset. The limbic system is basically where personality function is regulated and coordinated, and must be coordinated with the cortical and limbic functions mutually. This is just 4 examples. These frontal syndromes can look like all kinds of stuff. I can't hardly see this. So you may have a person who's perfectly cognitively intact, cognizant, intelligent, and appropriate, who acts sociopathic or unmotivated or impulsive. So this is an old thing from Gershwin: apathy, euphoria, and irritability. Identification is the big challenge for us, in my view. The index of suspicion, of course, is the first thing. You have to think of it. You have to have the history. Intact cognitive function does not exclude traumatic brain injury consequences. Histories of risks, we usually know that stuff. An unexpected effect of a trivial precipitant, for instance, why would 3 days after admission, 4 days after admission for alcohol withdrawal, patient's still on an Ativan drip, something else is going on. Commonly represented by prior traumatic brain injury, and excessive vulnerability to otherwise trivial insults to the brain, unexpected side effects of medications, a new onset of something that looks like major depression or a psychosis, changes in sleep, change in behavior, non-adherence to treatment or follow-up, history or symptoms that are inconsistent and don't just add up. You just need the history, and preferably some collateral history as well. And then you need more. You'll notice I underlined history. I think history is important. No specific treatments to recommend. So management, what best to do. Generally speaking, we try to keep it from getting worse. If you can stop progression, you have a chance for homeostasis to take over, and their recovery is possible. And there is some neural healing potential, but you got to stop the progressive cascade and the vicious cycle. So sleep is one of the big things. Polysomnography if necessary, just to understand what the sleep architecture is. Quetiapine is listed specifically only because there is data to indicate that it's sleep architecture neutral. Does not tend to suppress REM and deep stage sleep as sedative hypnotics do. Somebody with brain injury doesn't generally do well with Ambien, certainly not with Ativan, etc. For partly that reason. You add some iatrogenic sleep fragmentation and cumulative deprivation with that. Treat symptomatically. If there's mood instability, pharmacologic stabilizers work fairly well. A good example. Antipsychotic drugs can be used. There may be indications for opiates, which may or may not be unavoidable. Benzos or stimulants, but got to be cautious with them because people with brain injuries are vulnerable to side effects and adverse effects. There's no guidelines for the treatment of post-trauma depression. Antidepressants have mixed and unpredictable results. Generally speaking, low dose with close monitoring, if indicated at all. They don't tend to be all that effective. If you can correct some of the other things, depression usually improves. The functional limitations are actually kind of hard to understand from one visit to the next, and collateral information on that is useful. You need the family. What exactly can the patient not do that's given them functional problems, compliance problems, whatever you're seeing? Neuropsychology is extremely useful if it's available, and if you have neuropsychological evaluation available that's educated in the evaluation of traumatic brain injury outcomes, particularly the executive function assessment, which is really hard clinically. Psychiatric consultation when indicated. However, I would advocate not just referring to psychiatry because of symptomatic presentation and assuming this is a psychiatric condition primarily, because the psychiatrist may not know any more about TBI than you do. Collaborative care is better. Generally, a rehabilitative approach is good if you can spot what the functional limitations are. There is some brain injury resources available locally, not a lot, but try to find somebody in the rehab professions who is familiar with this kind of functional coaching, cueing, education. You don't need to go to counseling to deal with your past family traumas. You need to figure out how to do what you need to do. Neuroprotection would be the holy grail, but not yet. There is a lot of research. Again, it's focused, single agent, single mechanisms targeted. There have been no studies that demonstrate any consistently beneficial neuroprotective strategies. Having said that, correction of sleep, correction of mood instability, and overexertion tend to be neuroprotective. Limit progression, fix sleep, control hyperactivity, mood instability, general medical follow-up to spot weird things and make sure comorbid conditions are under control, prevent falls, etc. There's my wish list. I never trust that what's up there is the same as what I see, and I have to check. We need to identify injuries, whether or not we know they have chronic consequences, because we don't have adequate history available to us in most cases. It would be nice to have a registry, something that goes on the board in the ER or in the primary care practice. When the history is identified, it goes on the TBI board for retrieval by subsequent providers or on subsequent visits. So then we know a little bit more about who's had multiple insults, who's doing poorly and who's not. And we don't know that now unless we recreate it at the time of whichever evaluation we are conducting. We ought to have a little more focus on the specific evaluations and rehabilitation parameters for people specifically suffering from traumatic brain injury consequences in multiple disciplines, the rehab disciplines, social work and case management, and acquired brain injury syndromes ought to become part of the curriculum in psychiatry training, family medicine training, and others. We are going to need to deal with this. We're going to need more neuropsychology resources. We're going to need more neuropsychiatrists. And we need some guidelines, basically evidence-based data about how to manage these various common consequences, particularly mood disorders, post-traumatic PTSD, all that stuff. cases I can tell you about, but I'd like to know if there's any questions or comments. Somebody here knows something I haven't thought of, and I appreciate hearing it.
Just a quick one. What dose of quetiapine are you talking about for sleep regulation?
It varies, but if that's what I'm aiming at, I would start low. My own habit is take 25 milligrams sometime before you're going to go to bed. If you're not asleep in an hour, take another 20, 25, and see if you're groggy the next morning, but otherwise okay, do that again the next night, because the first night hangover is fairly common and not particularly meaningful. If it's not tolerated, you have to think of something else. If it does nothing, you titrate up. And it may be a temporary measure if you can establish a sleep rhythm. It doesn't mean you're putting somebody on quetiapine for maintenance.
Rick, a couple of questions. One is, do you think we should be sending all these people for formal neuropsychological evaluation, assuming the resources are available?
Given that, I don't think it's practical. I think if you have one or two colleagues in family medicine who are particularly interested and have seen a bunch of them, that's a good informal consult. I will usually request some level of neuropsychological consultation if I really can't figure it out and the history is highly suspicious and I need a differential and I need some detailed data for that purpose. And that could be a lot of cases and you can't get testing on all of them.
The other question is, when we tumble to these things long after the fact, is sending them to rehab of benefit beyond the acute phase?
Yeah, it could be. I have referred patients who've benefited from helping them recognize their own difficulties, for one thing, particularly with such things as fatigue. So they simply need coached to only stay on a ladder for 15 minutes and then take a break, because after 15 minutes they're always going to make mistakes. Simple stuff like that just needs to be looked at, kind of put in order, and the patient educated. Recognition that washing the dishes is actually not one task, it's multiple tasks. And how do you set up to do that thing that used to be routine? And rehab specialists that are accustomed to this are good at that kind of stuff. It does help because it cuts down on the patient's wear and tear and actually probably improves their long-term outcome.
Given the increased recognition of the problems and the long-term sequelae, what do you see happening with the sports world? I know there are schools that are canceling their football teams, but we're talking high school and fifth graders.
You thinking of football in general?
Soccer.
Yeah, I know. Anybody seen the book League of Denial? I understand there's a movie coming out called Concussion. You know about that? And I haven't seen it, but I think maybe I would like to. That whole thing, as you know, Mike Webster was a center for the Pittsburgh Steelers, who was inducted into the Hall of Fame in, I think, 1992. and he gave this speech that was all confused and rambling. Turns out he was sleeping in bus stations and accumulating assault weapons and writing letters to the NFL that were incoherent. And he died in 2002, I believe, of a cardiac event. Bennett Omalu was the pathologist on call. And Will Smith plays him in the movie, I believe, when we've heard. So he found a grossly normal brain, but he had seen stories on the television, so he decided to fix it and section it. And then forgot about it for a while, and when he looked at the slides, he said, "Holy cow." And he took it to a consultant who also said, "Holy cow," because it was all riddled with tau protein in a random distribution, diffusely, very little neurofibrillary tangle. And that started, the NFL proceeded to kick Omalu around, but a bunch of other researchers got on that. The NFL set up their own physician panel and their own research. And as far as I know, still fighting about it after some settlements. So, it would make you think, well, football ought to be abolished. And how can you let your kids do that? But what about soccer? What about baseball? People still box. I don't know. I was at lunch a couple of years ago with a neurosurgeon and a pediatrician, and we got to talking about this, and we all decided that nobody should play football. But I know at least the neurosurgeon's kid is playing football. You can't tell them they can't. And helmet design doesn't do very much. It's maybe a little better. Yeah.
Hi, I'm Dr. Felix. I wanted to ask about anxiety in post-traumatic stress symptoms. Is that pretty prevalent? And if so, is there ways of detecting it through the amygdala? Like that's supposed to be the center, I guess, where you have anxiety stored? Or could you explain that a little?
The most concise way I was told is the amygdala is a pessimist. That's very helpful for me to remember because the amygdala has several distinct nuclei that are responsible for fight, flight, and shutdown reactions. And it's also the place that would generate probably aggression and hyperactivation in general. So anxiety, yes, the short answer to your question is I think anxiety is quite common in people with brain injury, but it's got different variations. So when you see anxiety, what are the symptoms? Are they principally autonomic? Is it subjective? Is it fearfulness? Is it impulsivity, dysphoric mania? And how you treat it or attempt to treat it would kind of depend on the parameters. But it's hard. And again, I would look at basic stuff that can be corrected, like sleep, nutrition, function, fatigue in particular. People with anxiety are more likely to be more anxious when they're more tired. So again, that's kind of a rehabilitative approach. Thank you very much. I'm done.